TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
It is a pleasure to sit down with you and have a conversation today. I'm really excited to be talking with Dr. Elizabeth Salisbury-Ashfar. And so, welcome today.
Yeah, thanks so much. Really
Yeah.
glad to be here.
Yeah. So just to kind of start out, one of the things that I wanted to start out with is I think it's so interesting how our careers in terms of an education standpoint overlapped because your undergrad was University of Illinois and then you went to Rush
Yeah,
and that was my trajectory too. So it's kind of fun to see that.
that is fun. And
Yeah.
still both Midwesterners.
Yeah, that's right. That's right. Yeah, we're just a river apart.
Yeah.
Um, but what started you off on the career and the path that you've been journeying as a physician?
Yeah, I mean, I went to undergrad. I'm from a really rural community. And so
Okay,
I feel like growing up, we knew about like maybe 10 job paths that existed,
yeah,
medicine, nursing, teaching, police, like farming. Farming was a big
sure,
one.
yeah,
And so I went to undergrad pre-med partly because I was good at science and it was what I knew. And when I got into medical school, um, was lucky to have a few options, and I chose to go to Rush because I was really interested in working in a public hospital.
okay,
And of the schools in Illinois that I got into, they were the one that was directly affiliated with Cook County.
that's right.
And so I went there really with the intention of doing all of my work in public settings. And it was really there that I started to build this sort of propensity toward advocacy. It was also the first time in my life, like being from rural America, where I had seen both such extreme poverty. I had seen poverty, but
Yes,
not in the very visible way that you see it in urban settings, but
sure.
also such extreme wealth.
Yes, very true. Very,
And
very true.
I spent a ton of time, possibly too much time, volunteering in shelters and doing things sort of outside of medical school. And really thought I was going to be an HIV doctor, took a year off
Okay,
from medical school and worked on a project to eliminate maternal fetal HIV transmission. Went back, finished med school, went to family medicine residency. And basically, as I started down my career, I kept saying, I want to treat HIV. And they were like, get in line. So
yeah.
does
Uh,
everyone. We have more clinicians than we have patients.
oh,
So,
interesting.
and so I finished family medicine residency, still really committed to underserved and wanting to do HIV care, went out to Baltimore, did public health residency. And while I was there, the FQHC I was working in said, Elizabeth, we don't need you to treat HIV. If you want to be helpful, you should learn how to treat addiction because
Mm,
nobody wants to do that. Um, I was also working with the city health department, the state health department through my public health residency, and all of the projects I was working on were sort of interfacing with addiction.
okay.
And so that sort of felt like the universe telling me, like, okay, maybe you're not so needed in this
Yes.
HIV space right now. There's another space that was around 2010, and overdose rates were really
Really.
increasing.
Yes, that
And
was
yeah,
one of the inflection points for sure. Yes.
exactly. And so as I finished public health residency, I had the really amazing opportunity to move into this public health role as medical director of Behavioral Health System Baltimore, which I was not super prepared for.
Yes.
I had public health training, didn't have any formal addiction medicine training, and so was really learning on the job and super lucky to just have tremendous mentors all around Baltimore City who really took me under their wing and learned a ton. And I think the thing that honestly drew me in the most was this recognition that we had evidence-based services that worked really well and almost no one could access.
In homework, yes. Isn't
And
that the
people were
truth?
dying, and we saw tremendous disparities. And so this was kind of like, this is always kind of my sweet spot. Like, you know, I participate in some research, but don't consider myself a researcher. But it was like, oh, the evidence is clear,
Yes.
and all these people are dying, and there's this massive gap in between. What are we going to do about it? And
Yes.
that's really kind of been the jump off point for the rest of my career. I've, worked in Baltimore for 4 years. We were in Chicago.
Yes.
I was the med director of behavioral health for the city health department. I worked at Healthcare for the Homeless for 6 years. I've built out programs, supported program development, supported health departments, like all different ways of kind of thinking about these challenges,
Sure.
both at the individual level, the systems level, the policy level, and kind of love working across those
Yeah,
spaces.
that's what I've observed throughout your career is an openness first, and you mentioned it that kind of the universe was pointing you to where the need was, and so as I was listening to your story, I heard an openness to kind of where the need is and where the universe is pointing. I hear a willingness to go,
Yeah.
and then that recognition of there's clear evidence of what can help people,
Right.
yet there is a chasm between that option or options and the individuals who are most in need. What are your thoughts in terms of in through your career, what has contributed to that
Mm.
chasm? You know, those gaps where you find yourself right in the gap and then closing it. As you've done that, what are the causes of like those gaps?
Oh, I mean, so many, but I
Yeah.
think, stigma is always front and center.
Mhm.
And I think to dig deeper on why is the stigma there, as you know, I talk a lot about, like,
Yep.
a lot of it has been pretty intentionally placed to meet other political motives at varying times
Yes.
in our society, at varying times in our history. And systems get the results they get because of the ways that they're built.
Yes.
Um, and the disparities we see aren't just in addiction medicine. As you
They
know,
sure
they're
not.
not just in mental health care. I'm a family doc by training. I mean, it goes across the board. But I think that we have tremendous inequities in our society,
Sure do.
ranging from educational opportunities, housing opportunities, right? Living wage jobs. So
Yes.
the list is long. And then we have really a tiered healthcare system in this country. We don't believe that
We
healthcare
do.
is a right,
Yes.
and not everyone has access. And so I think that in some ways, like, it's not surprising that we have
No,
the outcomes
that's right.
that we have.
That's
But I
correct.
think when you layer on stigma and you layer on the really punitive approach we as a society have taken toward dealing with drug use and
Mhm.
people who use drugs, the high rates of incarceration and trauma, um, there's a lot there to unpack.
Yes. Yeah, very
And
much
so then
so.
the question, how do we address it? And I
Yes.
think that because of stigma, it's been hard for decades for impacted people to really step forward and talk about it,
Mhm.
talk about their personal experience, talk about the loss of a loved one. Um, and it's taken some really brave people
Mhm.
to do that work. And I always think about the fact that I'm standing on the shoulders of so many people who have
Yes.
really stepped forward in such a brave way.
Mhm.
Um, and I think where we can, through education, through advocacy, like continuing to make space for the folks who are most impacted to have a seat at the table is just really critical.
Yes. No, absolutely. Where do you see hope? Where are you seeing any progress in those the efforts to again narrow the gaps, but also to reduce stigma and to reduce the very real inequities that our institutions and our systems have created. I mean, I think you make a really strong point that when we see the evidence of those inequities, we're seeing the consequences of fairly intentional policies, right?
Yeah.
So that can be a bit depressing. Where are some rays of hope that you've seen?
I mean, I think there are many. So one, I was started volunteering at the Needle Exchange in Chicago in
Mm,
2004.
okay.
It's
Well,
the first place I
yeah,
learned about naloxone from the Chicago Recovery Alliance, which was really the pioneer in naloxone
y- very
distribution.
much so.
And I mean, in those days, one, we never learned about it in medical school.
Yeah,
Very few people outside of the syringe service program community even knew it existed.
absolutely correct. Yes.
Fast forward to today, there's naloxone in my kids' elementary school.
Yes.
So it is Very accessible. It is almost a household name. I mean, maybe not quite, but
Hmm. But
almost a
pretty
household
close.
name.
Yeah. No,
Yeah,
I agree.
the
Yeah.
level of accessibility and training, I think that is one sort of ray of hope, and we've done a really good job there. Similarly, I have hope. I mean, I do think that we've started
Hmm.
to reduce some of the barriers to things like medications for opioid use disorder, which we know are such life-saving medications. The elimination of the waiver, so the extra educational requirement for prescribers. Again, we still have room for improvement, but
Yep.
some reductions in some of the methadone regulations to allow programs to be more flexible and
Yeah, I'm
really.
excited about some of the pilots that are ongoing.
Absolutely,
Yes.
absolutely. And the last one, and again, I just, there's still a long way to go, but I think we're seeing, when we look at the spaces, um, where when we look at all the folks who overdose and we look at the places where we could have intervened and done a better job, and that's a lot of the work I've done in my public health roles in the
Yes.
past. There are a few really key places where we miss folks. One, we know that individuals with substance use disorders are disproportionately impacted by the criminal legal system.
Yes.
So lots of opportunities with police, with diversion, deflection, jails, drug courts. And we are seeing improvements, and we are seeing improvements in terms of, for those individuals, access to evidence-based treatments.
Yes.
Still room for improvement, and right, we're seeing grants, we're seeing funding opportunities, and we're seeing positive movement. Another is emergency department.
Very much so.
Having
Yes.
had one overdose really increases the risk that someone will have a subsequent overdose. Seeing tremendous improvements in our emergency departments in terms of getting naloxone out there, offering treatment initiation, linkage to community services. So I think we're moving in some good directions.
Yes.
And the last thing I want to acknowledge is just
Yeah.
harm reduction.
Yeah. Good.
Um,
Yeah.
and we've seen for the first time federal agencies really embracing harm reduction as a concept.
Yes.
We have a
That's been a
framework.
huge seismic shift. I agree.
Yeah,
Yes.
huge shift when you look at our recent trajectory. And so I think, I used to, I used to be invited to give talks on harm reduction to clinical audiences, and people would be pretty angry at the
Hmm.
concept, really this idea that they're
Absolutely.
dichotomous,
Oh,
that either
absolutely.
you're in favor of recovery or
Yep.
you're in favor of harm reduction. And I've really seen a lot more people move to the middle of this awareness that
Yeah.
recovery is part of harm reduction,
It's
like
part of
part
it.
of harm
Yes.
reduction, and abstinence is part of harm reduction. It's not the only part, but it's
Right.
a part.
That's right.
So I think lots of positive movement in
Yeah.
many directions that we just need to keep
Keep the
going.
momentum going.
Yeah.
Yeah, no, I agree. I mean, as you know, my career has been dominated in working in specialty substance use disorder treatment facilities, and in that setting, for most of my career, we did not talk about harm reduction at all. It was as you said, it was separate. And harm reduction is over there, and treatment is over here, and the two will not merge. And I equally have seen that there is a coming together and more dialogue in how it's a continuum, it's a spectrum of how we show up for the people in need.
Yeah.
So yeah, I agree with you. Couple of things that you have said that I want to just unpack a little bit further, and the first is to kind of go all the way back to the beginning when you were talking about the evolution of your career, and I heard a couple of things. One is early on this interest in public health and advocacy, and that's not true for a lot of physicians, especially early career physicians, although I think that too is changing. But I'd love to kind of just unpack how you found yourself moving along that trajectory and formally doing the public health residency. I
Mm.
think that's really fascinating.
Yeah, I think I would attribute it to a couple of things. One, I think growing up in a rural community, um, we have one school, like one middle school, one high school. Everybody's there.
Yes.
About a quarter of my class didn't graduate from high
Oh,
school,
okay.
um, and I think when you see so up front and center the ways that social determinants of health impact
Yeah.
people's lives.
Hmm.
So knowing really, really smart kids who didn't finish high school for a lot of environmental reasons, Having friends and family members who didn't have health insurance,
Yeah.
like
Sure. Yeah.
really kind of understanding the ways that all of these factors in adverse childhood experiences,
Hmm.
right? Having friends
Yeah.
whose parents were incarcerated, et cetera. Um, it gives you a certain outlook on the world that
Hmm.
not all physicians have.
No, very true.
And I
Very
want to
true.
be clear,
Yeah.
I was very blessed. I grew
Hmm.
up in a household with two parents who, like our needs were met. So I don't want to
Yeah.
misrepresent in any way, but I think having those experiences early on definitely influenced my view of the world.
Okay.
The next thing was when I started medical school. One, working in shelters, but two, I was really involved at a national level with the American Medical Student Association
Uh-huh.
and had exposure to some amazing, I will call them mentors, but like in
Yeah.
a more informal capacity.
Hmm.
Spent a
Hmm.
lot of time going to DC, on the
Yes.
Hill, learning from people. And that's really where I learned about, in my own medical, so I didn't even know preventive medicine was a field.
Oh,
Literally, we were
okay.
required to meet with the dean. And the med school dean, he said, "What do you want to do?" And I said, "I want to go into family medicine and preventive medicine." And his exact response was, "Family medicine is a dying field and there's no such thing as preventive
Oh
medicine."
no.
To which I mean,
Oh
I've always
no.
been like, that's,
Oh
I don't
yes.
let people get in my way a lot. To which I
Yes.
thought, okay, I think we're done here. Like
Yeah.
clearly we aren't going to see eye to
I
eye
could
on this.
totally hear you saying that.
Um,
Yes.
so I think, it's been this broader drive that there are all of these environmental factors and, working at Cook County,
Hmm.
I mean, I could tell people eat healthy, I could tell people exercise, but if you
Yes.
don't have those resources, how are
Right.
you going to do that? And
That's
so I
right.
quickly
That's
realized
right.
that there's some we can do in the clinic or in the hospital, but so much of it has to do with external forces. And so I became really interested in learning about how to address those.
Yes.
And I think over time, I will be honest, I don't think I'd ever be happy just doing clinical medicine,
Hmm.
nor would I be happy just doing public health.
Mm.
Because clinical medicine, most of the folks I work with now are unsheltered.
Yes.
And so it's real. The moral injury is so real. And
Yes.
just
Very
sort
much
of
so.
carrying all of these inequities with you all the time is really hard. So feeling like, okay, but I'm going to go work on this other public health thing
Hmm.
that at least gives me an outlet and gives me a place to be able to share some of these experiences and stories. But that work is slow.
Yes.
And
Very
I am
much
an
so.
impatient person, right? And
Yeah.
so just doing that work, you're constantly feeling like, oh my God, I'm going to be doing this for years and
Yeah.
never seeing an improvement. And so those individual relationships give me the momentum to continue to work at
Oh,
the
that's
higher sort of
really interesting.
community level or policy level. And I find doing all of it really invigorating.
Yeah. Well, it's evident. I mean, your passion comes through in this conversation when you're training, and I can only imagine what it looks like when you're in your clinic. Um, it that really helps me to understand what also from just a observer of your career sees that your career spans the national advocacy and looking at policy, but then you also are really active at the hyper local level. And now I understand how that interface serves you in your personal career. Can you talk a little bit though about the work that you are doing at the local level and in the clinic that you have developed? Because I think the audience would really be fascinated by the work that you're doing.
Sure, I would
Yeah.
love to. And I just want to say, none of the work that I or really any of
Mm.
us engage in is ever like a solo sport, right? Like there's
Absolutely.
just this massive team around me. So I won't be able to name
Well said.
everybody, but
No,
just
well
want to
said. Yeah.
call it out up front.
Well acknowledged.
So I live and work in Madison, Wisconsin, and it's a college town, and
Yep.
by many standards, we have great access to healthcare. I work on our inpatient consult team, and one of the things we were seeing is we were starting folks in the hospital on medications for addiction treatment, particularly buprenorphine, and then couldn't find anywhere for folks to follow up.
Yeah.
We have a
That's right.
massive primary care sort of access challenge locally, not enough
Okay.
primary care clinicians, and a really strong HMO market. And I only share
Hmm.
all that to say, like, people are very locked in to where they're allowed to go.
Yep.
And so while we know this is life-saving medication, we were really struggling to help people to figure out where to go and where to go quickly. Simultaneously, I was partnering with our emergency department and continuing to talk to our jail. And they're like, Elizabeth, look, we'll start the med, but where are people going?
Yes.
And I'm like, yeah,
Yeah.
it's a good question, guys. And so we were really lucky that the state health department or the state human services division put out a grant opportunity for a low barrier clinic.
Yep.
And so the model that we chose was a walk-in clinic for people who use substances. We offer same-day access to medications, but because of our partnerships with other community, like street outreach agencies, our needle exchange program, we also knew there were other unmet needs.
Hmm.
So hepatitis C treatment being a big one. Some PCPs treat Hep C, but not
Not
all.
all. No.
Also, sometimes access for folks who need it has been a challenge. We also, STI testing and treatment, wound care was a big
Yes, wound
one.
care is a big
A
one.
lot
That's
of
right.
just people feeling too stigmatized to present to the ER if they have wounds associated with injection drug use. So we built a clinic model, and I want to like
Yep.
underscore we
Yes.
that really aims to say if you are a person who uses substances, you are welcome here always.
Hmm.
Come on in, and we'll figure out what we can do.
Yes.
We have an awesome clinical team. We have a peer support specialist, a social worker, a nurse who works on the team. Medical assistant, and then a handful of prescribers,
Yes.
PAs and Ps and physicians, and together really work to hopefully create a really holistic environment. Our goal is not that people stay with us forever.
Hmm.
We will try to transition them. But there are a lot of folks for whom the existing structures, like show up on time, if you're late, we won't see you.
Right.
A lot of the folks we work with don't consistently even have a phone.
Mm.
And so just there are a lot of pieces.
Yes.
And so a good portion of the folks we're working with need to kind of stay in our treatment model because it's more flexible to meet their needs.
Yes. Oh, that's fantastic.
Yeah, it's been a great experience.
That's wonderful. You mentioned that this initiative started with a grant. Um,
Yeah.
I'm old enough to have lived through several cycles of grants, specifically in my career through mental health initiatives and wonderful clinics like yours grow up with the grant, and then the grants disappear.
Mhm.
And I've just experienced the true trauma for both the individuals and the communities being served and the health professionals when it closes,
Yeah.
like almost overnight.
Yeah.
Um, Thoughts on
Mm.
how we this time create sustainable systems that can exist beyond grant cycles?
It's a great question.
Yeah.
So I have had the opportunity to do a lot of program development over
Hmm.
the years. And so when we started building the program, we've had an eye toward this from the get-go. Most of the services we deliver are reimbursable. That one of the things the grant has allowed us to do is provide care for folks who are uninsured at no
Okay.
cost and
Yeah.
pay for medication and
Wonderful.
medical visits and labs. Um, that I haven't yet figured out what we're
Okay.
going to do
Yeah.
when the grant ends. We are actively working on it, but I think so that's a big piece.
Yes.
And our local federally qualified health center is amazing and hasn't had the capacity to accept new patients in over a year
Oh
because
my.
that would be so.
Okay.
When we are like providing intakes for patients who are uninsured, we're already telling them, look, our grant ends in September. We're working on a plan, but we just want to give you a heads up.
Yes.
And so we don't want anyone to find out 2 weeks before that all of
Sure.
a sudden the rug's being pulled out from under them.
Yes.
So we are looking at any and all
Okay. Okay.
opportunities for funding specifically for care for uninsured folks.
Yes.
I think really where grants, when they're, and I've been in the opposite position of being in roles where we're deciding who gets funded.
Yes.
And so I think, really always thinking about this as seed money, right? So it took us a good number of months to really, to build trust with the community,
Sure.
to have people like a walk-in clinic, you got it, like
Yes.
people got to know about you.
Hmm.
So, so I think that's really helpful seed money to like have a timeline to be able to build all the systems, the programs, get your name out, meet with all your community partners, It's slow at first.
Yes.
So, had it been something like we would have been losing a lot of money by having
Yes.
such a
Right.
comprehensive team. So
Yes.
that takes time. And so I think we're now in a position where our volume is sufficient for the folks, at least who have insurance or
Yes.
predominantly Medicaid, to be
Medicaid.
seen. But it's the care for the uninsured folks that we're really going to struggle with
Yes.
when the grant ends. And similarly, our peer services, we don't have a reimbursement mechanism right now. So
Okay.
also looking.
Wisconsin doesn't have peer reimbursement.
It's a complicated answer, but the short answer is it's not in place yet. And even
Okay.
when it is, our clinic won't be eligible because we're
Oh,
not a licensed
understood.
OUD,
Yep.
or a
Yep.
licensed SUD program.
Yes.
We're like a more comprehensive medical model.
Understood. Yeah,
Yeah.
that is certainly a gap
Yes.
across many states, that there's not kind of the recognition that there are different clinics that are showing up to provide the services. And so it's not always that it's a licensed SUD clinic
Right.
that's providing the services like you are.
Right.
And we haven't closed that gap yet.
Well, and I think it's so interesting. One of our past addiction medicine fellows and a close colleague and friend works for a licensed SUD treatment program. And she's an internist
Hmm.
and she's really interested in providing Hep C treatment.
Uh-huh.
But when she tries to deliver it, everything keeps getting bounced back because
Oh
they're
no.
saying, you're not in a medical clinic, you're in an SUD clinic. You
Yes, there
can't
you
do
go.
this,
Yes.
even though it would by far be the
Yeah.
best thing for the
Hmm.
patient, right?
Yes. Yeah. No, you're speaking of, again, the historical and institutionalized silos that our systems of care
They just don't make
have.
any sense, right?
No,
And they force,
agreed.
like, you guys get to bill this way for only these things, and you guys get to bill this way only for these things. But that's not
That's
how
how it
what our
works.
patients need, right? Like, our patients need all of it, and to be bounced around
Yes.
constantly, especially in a world where we're seeing so many access challenges, just doesn't make any
No, it
sense.
really doesn't. You mentioned that your career has been influenced on a number of occasions by mentors, and
Mm,
even yesterday when you were lecturing, you spoke of a mentor in Chicago.
yeah.
I think that that's often an overlooked part of our field and our careers is the importance of mentors coming into our lives. And I just wanted to see if you could speak to some of those mentors that you have had.
Yeah. My career's been pretty non-traditional, and I
Hmm.
think some of my mentors, at least for physician, are
Yeah.
also fairly non-traditional. Definitely dating back to medical school. I mean, I went into family medicine because I saw people really, other family docs, really modeling behaviors that I deeply respected, right?
Mm.
So the folks who were precepting us in the homeless shelters, the folks who were doing community outreach. Family medicine is not often viewed in academic centers as like the most desirable field.
Very true.
But when I looked around at the work people were doing, I was repeatedly just kind of in awe of
Mm.
all of the community engagement element that I saw a lot of our family medicine docs delivering. So, I mean, that was one. I also just, I've learned so much from folks not in medicine.
Yeah.
So the
Yeah.
person I mentioned yesterday, Dan Big, was from the Chicago Recovery
Right.
Alliance. And Dan just had this belief that like you just do what's right and things work
Hmm.
out,
Yeah.
which hopefully is true.
Yeah.
But I
Yeah.
think really pushed a lot of the limits for what
Mhm.
I thought might be possible, or the ways I thought that we could or should do things.
Yes.
Um, and that, gosh, there are just so many. And I think the other thing I would say is that we should never underestimate. I think sometimes when we hear the word mentor, we think of this very formal
Hmm.
relationship where you meet for coffee so many times a year.
Yes.
Uh, a lot of the mentors I have been much less formal.
Absolutely.
People
Yeah.
who let me come and shadow, people who I found inspiring and have followed their careers. Sometimes they're people more senior than me, and sometimes they're people more junior than
Hmm.
me.
Sure.
And so to never forget that like
Yes.
we're always modeling,
Oh,
people are
well said.
watching, and that we might be inspiring someone we don't even know.
Absolutely. Well, that's certainly true of you.
Oh,
You are inspiring. I have thoroughly enjoyed our conversation today. Is there anything that we haven't talked about, or kind of that one message that if there's someone who's watching this who is themselves dealing with a substance use disorder, or a loved one with a substance use disorder, something that you'd want to leave them with?
Oh, that's a good question. I think that there's still so much stigma in our society, and there's still, um, there are a lot of punitive responses. It's scary to
Very much.
acknowledge that you need help, and people worry about losing jobs, losing kids.
Yeah.
Lots of potential negative repercussions. Um, And I guess I would just say that I think like finding community
Mm,
and looking for resources that fit people's needs, as we've talked a lot about, there's
yeah.
no one size fits all. I've seen people recover, and that's a very broad
Broad,
definition,
yeah. Mhm.
in many different ways. And, I was having a conversation last night, when I've worked with folks who are really, really struggling, sometimes for years, and then they turn a corner, it's almost never because of something that I've done, right?
Mhm.
It's because they finally got housing. It's because a family member came back into their lives. It's because they got a job that really brought them purpose and meaning, right? And so we just never know when that's going to happen
Yes.
for people. And so
Yes.
I think like if you're a family member, being patient, offering supports, of course, sometimes there are times when family members need to build some of their own boundaries for their
Mhm.
own safety and,
Yep.
and wellness. But it's a long path.
Mm.
And it looks different for everyone, and that's okay.
Yeah, well said. Thank you very, very much. Um, we've covered a lot of ground, and that didn't surprise me because your career covers a lot of ground. And thank you so much for
Yeah.
sharing insights into the work that you do, spanning from national level advocacy and policy work to again that hyper local in the community, providing low barrier, same day walk in. I mean, what an amazing spread. If someone wants to get more information or connect with your work or become involved in advocacy, what are some ways that they could reach out and connect?
I'm always happy to be emailed,
Okay.
and LinkedIn is probably the fastest, easiest way to reach out.
Okay.
And I do just want to say one last thing, if that's okay, Steve.
Absolutely.
So I think in medicine and in healthcare in general, we're sort of trained that there's a certain trajectory that we need to follow, and there's a certain lane that we need to stay in.
Hmm.
And I think that it's really critical that we're always asking questions about why things are the way they are. And anytime the answer is because that's how it's always been, we should really keep questioning.
Yes.
And that big systems change slowly, but they only change if someone's working to change
Yes.
them.
And they do change. They
And they
can
can
change.
change, right?
Yes.
And so I think so often when I talk about some of the advocacy work I've done, people would say, "Yeah, but how did you do that?" I'm like, "I don't know. I just showed up to a community event and started asking questions
Yeah.
and offering more information and nudging and pushing and yeah, I'm sure I'm annoying to people at times, but right, like somebody has to be willing to do that work. And as healthcare providers with letters after our names, while totally unfair,
Yes.
we do have more power than we
That's
realize.
right. Yeah. No,
Yeah,
very, very well said.
yeah.
It has
Thank you.
been a pleasure. I knew it was going to be a pleasure, and it was. Thank you so much for
Yeah,
spending some
thank
time
you.
with me.
Thank you so much for
Yeah.
having me.